Good evening. Welcome to Spine Time. Dr. Jadwani, please go ahead and begin your presentation.
Sure. Well, welcome everyone. Welcome to our regular Spine Time. I'm very excited to be hosting today with two of my colleagues, Dr. Boltanova, who I've known since my very first day of residency as we were co-residents, and now attendings together at the Spine Center. And then one of my mentors, very good friends, Dr. Paracha. It's really an honor to be able to talk to you guys today about a topic that's very near and dear to all of us, which is medications after spine surgery. So we're gonna chat a little bit today for everyone in the audience about how we manage, the post-operative course after spine surgery. What are the different classes of medications that we use, why we use those medications, and how ultimately we think about things in a very multimodal way in order to have good outcomes after spine surgery. The three of us are anesthesiologists by training, but we also have specialized training in pain medicine. And so we are the kinds of folks that see people before their spine surgery. We take care of people during spine surgery. We take care of people in the recovery room after spine surgery. And then even days afterwards and months afterwards, we're still in contact with patients, taking care of them and their medications. So it's very excited to be here. Let's go to the next slide. Very good. Well, a lot of folks here, if you've never tuned in before, this is our Spine Time bi-weekly webinar that we have. Spine Center that we have on 59th Street is really a labor of love between a lot of different departments, including pain management, which is the three doctors that are talking to you today, spine surgery, neurology, rehab medicine, as well as integrative approaches with complementary medicine, and then even mindfulness-based stress reduction and CBT. So one center housing many doctors who are all thinking together on how to get patients pain-free and back to their normal lives. Next slide. I already mentioned my two guest speakers today, Dr. Boltanova and Dr. Paracha. Next slide. Great. I'm going to start by handing over to Dr. Boltanova to start talking about probably one of our most common line of medications to use during the perioperative phase, which are non-steroidal anti-inflammatory drugs.
Hi, everyone, and thank you for the introduction. So NSAIDs, or non-steroidal anti-inflammatory drugs, as Dr. Jadwani was saying, are one of the most common medications that patients receive following spine surgery. The reason these medications are so popular is that they not only can reduce pain, they can also reduce fever and help with inflammation after spine surgery. The way that they work is that they block an enzyme called the cyclooxygenase enzyme. And by doing that, they in turn inhibit the production of inflammatory molecules called prostaglandins, and in turn reduce inflammation. These medications can be administered either orally or through the IV. So the oral forms of these medications, many of you are probably familiar with these names: ibuprofen or Advil, naproxen or Aleve, and celecoxib or Celebrex. A potent form of an anti-inflammatory medication can also be delivered through the IV. This medication is known as ketorolac or Toradol. Some caution with anti-inflammatory drugs is that they can have some side effects. So commonly they can cause some stomach irritation. Additionally, we may avoid the use of anti-inflammatory medications or use caution if a patient has problems with their kidneys, if they have significant heart disease, Additionally, if they're at an increased bleeding risk after surgery, or if they have a history of stomach issues such as stomach ulcers.
Great. Well, let's stop there. For members of the audience, if you have any questions, feel free to use the chat feature and type them in there. I'm always looking to see if there's any audience questions to ask after we go through each drug class. But a quick question to my two esteemed panelists. So, is there a difference between the kinds of NSAIDs that you get over the counter at, say, a CVS and the kind of NSAIDs that we prescribe in the operating room or maybe at the pharmacy?
I can take that. So there's a few unique aspects. One is the dosing can vary. So higher doses can be possible via prescription. The other more important component is some of the more prescribed NSAIDs are selective. So unlike the traditional ibuprofen that you can walk into the store and get, there's medications that are selective inhibitors for pain and therefore have less effect on, say, the GI system and the stomach. Those do require a prescription. They can be more effective for patients, particularly if they have histories of having upset stomachs in the past, for example. So there's opportunity to maximize an improved side effect profile, but still give them the relieving factors associated with non-steroidal anti-inflammatory drugs.
Yeah, I think that's something when we're going through pain fellowship and we're learning about all these different class of NSAIDs, you realize that even though they all have the same name, they all don't interact the same way, and every person's a little different. And sometimes it takes a little bit of experimentation to find the right one for the right patient. We do have a couple of comments and questions. One question that's coming up is Tylenol. We'll get to Tylenol. Technically, Tylenol does not fall under the class of NSAIDs. Meloxicam. Any thoughts about meloxicam?
Meloxicam is a great anti-inflammatory. Unlike some of the other anti-inflammatory medications, one advantage is that it's one pill a day anti-inflammatory. So it can prevent you from having to take 5-6 pills a day. So that because it is longer acting.
Great. And then somebody asked, NSAIDs have always had this kind of backstory or adverse effect of causing platelet dysfunction. So a lot of times, folks can be a little concerned when starting them around spine surgery because of the risk of potential bleeding in spine surgery. So what are our thoughts on that? Platelet dysfunction in NSAIDs and use around the time of spine surgery.
So bleeding risk is always something that we discuss with the surgeon. So there's always shared decision making involved. Additionally, we always consider the patient's unique medical history. Anyone who's already taking, an agent such as aspirin that can affect platelet function, that may affect our decision of whether it's safe to take an anti-inflammatory medication. So the short answer is it depends.
Right. And then somebody else asked a question, can you take meloxicam if you're a blood thinner? And the answer to that, I'd always say is it depends. I think a lot of the literature around NSAIDs and bleeding is something that we're constantly reevaluating. 50 years ago, you would think that the NSAIDs were a blood thinner in and of themselves, and now we kind of have a different way of thinking about them. Not that they don't have some element of platelet dysfunction, but that we don't really see them as, we give Toradol all the time for many kinds of surgeries without seeing significant bleeding afterwards. But for every patient, it's a shared decision with the surgeon, with the anesthesiologist, with the primary care doctors taking care of the patients, and the pain management doctors taking care of them afterwards. And so the answer, unfortunately, is usually depends on the patient, how significant the bleeding risk is, the other kinds of factors involved in the patient's care. And so if you're interested in considering using meloxicam while on a blood thinner, always best to reach out to your pain doctor or anybody taking care of you to have that discussion. All right, let's move on. Tylenol. All right, this was a popular one. Dr. Boltanova, take it away.
Yeah, so acetaminophen, also known as Tylenol, is probably the safest pain medication that you can take after surgery, and it can be pretty effective. And although it's very common and very commonly prescribed, we don't actually fully understand its mechanism. It partially works as the same as an anti-inflammatory medication we described previously called Celebrex, as it inhibits an enzyme known as the cyclooxygenase enzyme. However, the mechanism is even more complicated, and we know that it also can affect the endocannabinoid receptors. Acetaminophen can be given either orally or through the IV, and studies show that both formulations have pretty similar efficacy. The maximum dose of acetaminophen for most patients is a total of 3,000 milligrams a day, broken up usually into 3 times a day or even 4 times a day doses. And it can be taken as high as 4,000 milligrams a day if it's used for a short period of time. Again, acetaminophen is safe for most patients. However, we do use caution, potentially a lower dose, or avoid the use of it altogether in patients with liver disease.
Okay. So somebody asked from the chat, is it okay to use both Tylenol and an NSAID like Aleve at the same time?
Yeah, generally, because their mechanism of action are completely different, and the interaction sparing, unless you have a liver dysfunction or kidney dysfunction, is safe to take. In fact, we will generally recommend that people can take an NSAID with Tylenol, just because the additive benefit and the different pathways can provide additional relief that them by themselves may not be able to provide.
Right. Here's an interesting one that I know all anesthesiologists have thought about this at some point. So we have access at New York-Presbyterian to IV Tylenol. And a common question that often comes up is there a difference between the efficacy that you've seen from IV Tylenol and the one that you take orally? Because, there's a lot of literature out there in the scholarly journals that say that there isn't. But a lot of anesthesiologists say that they do see some benefit with the IV version. What are our thoughts?
I would say that it depends. It's one of those things that can fluctuate depending on the situation. In some cases, people aren't fans of taking pills because, for example, anesthesia might make them nauseous. And afterwards, getting a pill may not be practical. So IV Tylenol becomes a very important role. Generally speaking, most studies don't necessarily show a difference, but obviously IV Tylenol also has the added benefit of us being able to administer it while you are asleep under anesthesia, allowing you to have better outcome when you wake up. So there are certain opportunities you can maximize with IV Tylenol that otherwise pills don't allow you for. But the jury's a bit out because it sort of depends on the person and depends on what the situation is and kind of when the medicine wants to, you want the medicine to be administered.
Right. So somebody asked, is it usually okay to use Tylenol alone after surgery for post-op? Is it enough? What are our thoughts? So somebody comes out of spine surgery and, we're just using Tylenol alone. Is this something that you would recommend?
I think in general, yes, we definitely recommend the use of Tylenol. I think depending on the surgery, it can potentially be sufficient, but again, it depends on how extensive the surgery is. But yes, I think acetaminophen would be a great starting point.
Right. And somebody, on the chat mentioned from personal experience, there is a difference between, I assume what they're talking about is IV and oral Tylenol, but it's cost limited IV use. I'd say that you're right. There has been at times considerations that IV Tylenol is more expensive than the oral kind, but I've really seen over the past few years our thought process change on this and a lot more availability of IV Tylenol at New York-Presbyterian. And so Alina, when you and I started residency, it wasn't that common that we'd see it. And now I think we have a lot more access to it. Okay, very good. Let's move on. Let's talk about anticonvulsants next.
Yeah, so anticonvulsants. So these are anti-seizure medications. So you may be wondering why would I be getting this after surgery? So these medications actually help with nerve-related pain after surgery, and it's not uncommon after spine surgery to have some nerve irritation causing numbness or tingling or a shooting pain down the arms or legs, depending on the site of where you had the surgery. So two common medications that we may use to help with nerve-related pain after surgery are gabapentin, which is also known as Neurontin, and pregabalin, which is known as Lyrica. So the way that these medications work is they basically reduce the transmission of certain excitatory neurotransmitters, or which are basically chemicals in the nervous system. And basically by reducing that, it helps to reduce the transmission of pain signals. These medications do have some side effects associated with them. Commonly, these side effects include drowsiness and dizziness. So we will often start patients on a low dose and slowly go up on the dose over the course of days if you're in the hospital, or often weeks in the outpatient setting, to help minimize these side effects. Some other side effects can include blurry vision, headache, and swelling of the extremities. Again, overall, these are safe medications. However, they can be quite sedating. And so we tend to use caution in patients above the age of 65, and also in patients with kidney disease who may need an altered dosing regimen.
Great. Thank you so much. Now, there's been a lot of thought over the past few years about the use of medications like gabapentin and pregabalin for spine surgery. And when we developed enhanced recovery pathways, these played a prominent component of that enhanced recovery strategy. How have we seen this play out, over the course of the past few years for patients after spine surgery? Dr. Paracha.
So, we still use it as a part of our regimen, but in recent research and studies, people have found that maybe we've been depending a little bit too much on them. I still think it is a mainstay of therapy, but I think the most important component of a lot of the stuff you'll hear today is using that multimodal approach. I think having a few different classes, if not many different classes of medications, at more moderate dosing is actually more effective than really heavily relying on one or two medications. And we generally find that, in my experience, that if you think of pain as a bit of a highway with multiple lanes, we're trying to block as many of those lanes as possible. And to make that easy and make it possible at all, we do have to use these different families of medications. I still find that gabapentin and Lyrica for certain types of neuropathic or nerve pain can be quite beneficial, but it by itself may not be enough for someone after a spine surgery. And that's why we're talking about kind of these other categories of medicine.
I really like that metaphor. I like that metaphor of the highway with multiple lanes. I think I'm going to start using that one as well. Very good. Somebody asked, what about lamotrigine, otherwise known as Lamictal?
Classically, many anti-seizure and anticonvulsants have been tried for pain. in my experience, as well as the studies that are out there, we've been able to narrow it down to a lot of the typical ones that we use, which are gabapentin, Lyrica, occasionally topiramate. Things like oxcarbamazepine, carbamazepine, Lamictal do have some validity, but now we start moving into the tertiary and quaternary degrees of medicines when it comes to this class. I would still lean more heavily on the more tried and true gabapentin and Lyrica before I would jump to something like Lamictal, mainly because Lamictal also comes, specific to Lamictal, comes with a variety of side effects that are probably more intrusive than things that are associated with our typical anticonvulsants for pain.
Yeah, I agree. When patients fail kind of the first and second line, we start thinking about the third line agents. But, in the postoperative setting, when we're already using other medications that may have side effects, we really want to limit the amount of, polypharmacy that have sort of consequences, because it can be hard to tell if patients are too sedated afterwards, what may be causing it. So it's definitely a tool in our toolbox, but it would be a tool that we would use later on, not maybe our initial thought process. Okay, very good. What comes after anticonvulsants? Very good. Muscle relaxants.
So muscle relaxants. So it's common to have muscle spasms after spine surgery. So we often feel that the addition of a muscle relaxant can be helpful. There's a variety of muscle relaxants out there. Some of the common ones include cyclobenzaprine, which is also known as Flexeril, tizanidine, which is also known as Xanaflex, methocarbamol, also known as Robaxin, and then baclofen. Because there's so many medications out there, they do have different mechanisms of action. However, in general, they do act on the central nervous system. Similarly, as with the anticonvulsants, muscle relaxants can have some side effects, and they do have some similar side effects, including sedation, dizziness, and confusion. So in general, we do use caution with muscle relaxants, and especially in patients above the age of 65 because of these side effects. We may also use caution in patients with kidney disease, liver disease, and then if patients are using Flexeril or taking Flexeril, we wouldn't want them to be on taking antidepressants at the same time, because those medications can actually have a very similar mechanism. So typically, if a patient is taking an antidepressant, we'll avoid the use of that specific muscle relaxant and favor some of the other ones.
Okay. Question from the chat. Is it true that there have been some studies recently that suggest that Flexeril may cause memory difficulties?
So one of the kind of secondary issues with muscle relaxants is because a lot of them are centrally acting, the side effects mimic what you would expect from a centrally acting medication. What do I mean by that? For example, Flexeril's mechanism of action is similar to classically tricyclic antidepressants, and therefore they play a role in the way someone can think and someone's focus can be altered by taking these medications. Unfortunately, we don't have targeted muscle relaxants that don't necessarily only work in the periphery. They all have some element of sedation associated with them. So it can be challenging, and all of them do have some element of sedation that tends to go with their muscle relaxant effects. And again, that's why I want to use the opportunity to mention that we use this multimodal approach. If we can divide out the side effect profiles amongst many medications at lower, more infrequent dosing, then typically patients tend to do significantly better from a side effect profile standpoint.
Great. And I want to be cognizant of the time and our audience. So I'll have us move along, and who knows, maybe we can capture some of these last minute questions at the end.
So
Opioids.
so the next category of medications is opioids. So these are narcotic medications typically used to treat severe pain after surgery. They can be administered as oral medication, and some common oral medications include oxycodone, morphine, and hydromorphone, also known as Dilaudid. These medications can also be given through the IV, and oftentimes it's a similar medication. So Dilaudid can be given through the IV, so can morphine. There's no IV form of oxycodone, but fentanyl can also be given through the IV to treat severe pain after surgery. Sometimes after surgery, if the pain is very difficult to control, or if someone's had a very extensive surgery, a patient may receive something called a patient-controlled analgesia, or PCA pump. So that's basically a button that a patient's given to press that where they receive a certain programmed amount of IV medication, and it prevents the patient from taking too much opioid medication, because basically the PCA pump prevents them from doing so. So it kind of has a little safety mechanism in place to help reduce side effects, although it does not eliminate side effects. And the side effects of opioids can be quite extensive and quite significant. Some of the ones we worry about the most are depressed breathing, nausea, vomiting, constipation, drowsiness, and confusion. And then we also know that for any patient, there's always many risks involved to the use of opioids, even for short periods of time. All patients are at risk of developing tolerance, dependence to opioids, addiction, and a phenomenon known as opioid-induced hyperalgesia, which is basically a term that means increased pain sensitivity. So being on these medications, especially for longer periods of time, can increase your sensitivity to pain. So in general, we use caution in all patients when considering the use of opioids.
Very good. I want to make sure we also get to any more medication classes. So we'll start taking questions at the end. Great. Does somebody want to talk a little briefly about the intravenous infusions for pain?
Sure. So we've kind of focused a lot, with the exception of some of the IV medications mentioned, on medications that are mostly taken by mouth, and different classes of medications that can help with different types of pain, particularly those associated with post-operative spine surgery. But I wanted to spend a little bit of time talking about some of the things that we can do intraoperatively and postoperatively, strictly in the hospital, because we have the opportunities to run some of these novel infusions to help with pain. And there's 4 of note, and we commonly use either some or a combination thereof in different patients, depending on the situation. And they each kind of have additional benefit that can be added to people's pain control, in addition to the stuff that Dr. Boltonova had already gone through. So the 4 that we most commonly will use are magnesium, dexmedetomidine, ketamine, and lidocaine infusions. And I can go through them one by one, but we can start with the lidocaine infusions. So one of the benefits of lidocaine infusion is it definitely provides improved pain control, mainly because of the mechanism of action. It blocks sodium channels, which is the main conduction pathway that our nerves use to send signals, and that's inclusive of nociceptive or pain nerves. They do have an effect of opioid sparing, which is great, because not only does that reduce the amount of opioid you may need for the same level or better pain control, but the side effects and the potential downsides that Dr. Boltonova just mentioned, which are things like tolerance and hyperalgesia, it reduces those risks. So it gives the opioid more opportunity to work. One of the other issues that are sort of default when it comes to general anesthetics, you have bowel function issues. You can become constipated or have what's called an ileus afterwards. And things like lidocaine infusions can help, along with these other infusions, can help reduce that risk by reducing the opioid load, which can definitely mitigate the amount of ileus someone has. And then postoperative nausea and vomiting is a big component of general anesthesia as well as some of the other medications that were mentioned. So the nice thing about lidocaine is that it reduces that risk significantly.
Great.
The next drug that we can chat about is ketamine. We are frequently more and more using ketamine. We've made a pretty strong initiative at our hospital to try to make it more easily accessible by allowing patients in lower type units, so post-operative typical units and step-down units, to have it available for patients. The way it works is it uses kind of a back door, I would say, for the pain signal. Typically, opioids block our mu receptors. Ketamine is an antagonist of a different receptor and called the NMDA receptor. It functions in treating and sending pain signals. So by using ketamine, you can really interact with it in an opioid-sparing manner that really reduces the amount of pain people have post-operatively. And this is all via intravenous administration. It can also be used in the intraoperative setting, so patients can actually get it while they're asleep before they wake up to help prep them for a postoperative period that can be significantly less painful. And then it definitely reduces not just pain in the acute setting, but it's been shown to reduce occurrences of chronic pain pathology over the long term. So 3-6 months in a year as well. So it can be a very important strategy. One of the downsides of ketamine is that because it is an analgesic and anesthetic, it can cause a little bit of not just sedation, but some weird dreams and different kinds of visual alterations. But that can be very easily managed with additions of medications to help mitigate that effect. One of the less commonly used, but still very effective things that are underused generally in most pain populations is the use of magnesium. It has quite a bit of anti-nociceptive, again, pain effect, and it interacts with that same NMDA receptor, which is why we think it works really well. It additionally has this added benefit of being a naturally occurring muscle relaxant because magnesium is used in the muscle conduction pathways. And like the other infusions, can reduce the opioid and anesthetic requirements, and therefore gives the opportunity for those other classes of medicine to work more effectively. And then lastly, one of the commonly used infusions is dexmedetomidine. So we have multiple case reports and multiple studies that show it can reduce significantly the same risks that we have associated with opioids and general anesthesia, which is the postoperative nausea and vomiting. It definitely helps with anxiety and agitation as well. So post-operatively, sometimes people have struggles with that, and that can help mitigate that effect. It has an opioid reducing component like the other infusions. And it also allows for the pain pathway to be utilized in, a different way. It uses an alpha-2 agonist activity, which at the central level can reduce the pain signals that are sent and can help with the pain management post-operatively in the acute setting.
Very good. So that pretty much covers a lot of different medications that we utilize to take care of people before, during, and after their spine surgery. A lot of these things that we're doing here at New York-Presbyterian, are designed around, like Dr. Paracha and Dr. Boltanova have been saying, a multimodal approach. No one medicine is the, silver bullet. It's really through a combination of them and balancing their side effects that we get patients through this recovery period. Any last thoughts, any last questions from the audience? So there was a comment about, the ongoing opioid epidemic and how it's, sort of changed, our perception of prescribing opioids in the setting of surgery. And, to that, I think all of us being anesthesiologists who use opioids every day as part of our anesthetic practice, have come to appreciate that opioids do still have their place in taking care of pain during and after surgery, but there's a lot of work that's been done to try and come up with alternatives as well, to ensure that we're giving patients a really balanced, pain management with less risks to tolerance, to hyperalgesia, and to addiction. And then we have another, what side effects with, believe that's dexmedetomidine, do you find regularly?
I would say the most common effects are there's a bit of sedation that's associated with it, so people get a little sleepy. There can be, along with that, some blurred vision and dizziness or lightheadedness, and that all comes because it is a sedative at baseline. Sometimes it can cause a little bit of decrease in your blood pressure as well as a decrease in your heart rate. But that's why these are usually given in the hospital setting. So those things can be monitored very closely, and we can keep an eye on it to make sure your cardiovascular function is good.
And then there's a question about UTIs. Can gabapentin or baclofen cause UTIs? I think I have not seen very strong associations between the use of those medications and urinary tract infections specifically. Is it possible that patients who are getting more baclofen and more gabapentin are more sedated and therefore having, or in situations like in the hospital or in nursing homes where there's a higher rate of UTIs? I think there may be some element of that as well. So while I've yet to see, although I'm not an expert on UTIs, any literature associating the use of those medications and UTIs specifically, I can see why some patients who are on those medications might be in a situation where UTIs are more prominent. Okay, very good. Well, at this time, I want to thank our panelists today, Dr. Boltanova, Dr. Paracha. Thank you so much for taking us through all the various medications that we use to treat pain in the setting of spine surgery.
Thanks for having us.
Of course.
Thank you, everyone.
Bye.